Hello, and very warm welcome to all the attendees to this COVID-19 and mental health webinar. My name is Shekhar Saxena. I teach at Harvard School of Public Health, and I will be the moderator for today's webinar. The webinars are in a series that is organized by United for Global Mental Health and also supported by the Lancet Psychiatry, MHPSS Net, and the Mental Health Innovation Network. These webinars have been on since 7th of April, and we believe they are serving useful purpose. I can see more than 100 people joining in already. So we think this will be a good use of your time. The topic for today's discussion is no health without mental health, integrating mental health into health systems. I will like to introduce the topic first and then introduce our speakers. And this seminar of 45 minutes, we believe will serve a very critical purpose in this series by getting some experience globally, but also from a particular country about how the mental health is being integrated into health systems, and especially in the context of the COVID-19 pandemic. Most of you will recognize that integration of mental health into health system is not something new that we're talking about today. It has been talked about for several decades. Some of us will remember that in 1978, there was the Alma Ata conference organized by WHO and UNICEF, which talked about health for all by year 2000. Of course, the year 2000 came and went, and some progress have been made. But still, many of us believe that we are far from an adequate integration of mental health into health systems. No health without mental health was also the title of a paper as a part of the Lancet series on global mental health in 2007. And obviously, universal health coverage, which is a related concept, is also part of the Mental Health Action Plan of WHO 2013, now extended to 2030, and also part of SDG 3.8 of the United Nations. What is universal health coverage? In very simple terms, it is healthcare for everyone, everywhere. In a slightly longer version, it can be said that it is ensuring that people have access to healthcare they need without suffering hardship, financial hardship, and also it is person-centered and rights-based. Since the definition of health by WHO does include mental and social well-being, it is logical to believe that universal health coverage must include mental health in all its parts, prevention, promotion, as well as care for people who have mental disorders. And it should be always a part of healthcare, whether the country recognizes universal health coverage as its framework or not. And we'll hear very soon more about that. COVID-19 pandemic, which is affecting all of us and all countries, has put an urgency to the requirement of integration of mental health within the universal health coverage. And that is the topic for today's discussion. Does it facilitate? Does it put more barriers? Does it provide opportunities? How it is being done globally, how it is being done in countries, and what can we do to actually improve the implementation of mental health as a part of universal health coverage. For discussing this, we have 4 speakers who are eminent in their own right. I will like to introduce them now. Our first panelist will be Dr. Githinji Gitahi. He is the global CEO of AMREF Health Africa and also co-chair of UHC 2030. Welcome, Githinji. Our second speaker will be Devora Kestel, who is the director for the Department of Mental Health and Substance Use, WHO Geneva. Welcome, Devora. UHC is something that I know you are very passionate about, so we look forward to hearing you. We have 2 panelists from one country, which is very, very unique today. We have Dr. Akwasi Osei, CEO of Mental Health Authority of Ghana. And we also have very soon, hopefully joining in, Peter Yaro, who is the Executive Director of BasicNeeds Ghana. So we've focused on Ghana as a country to give an example of the kind of progress that is being made and what can be done to facilitate that. For all the attendees, feel free to put questions in the chat, but also feel free to write an email to COVID-19 seminars@unitedglobalmentalhealth.org, and your questions will be monitored, and hopefully we'll have time to answer some of these questions by the panelists. Also feel free to go to social media and give your comments or inputs or ask questions at COVID-19 MH on Twitter as well as on Facebook. So let's begin with the panelists. And I would like to request the panelists to be brief so that we can cover as many questions as is possible. As was said earlier, this webinar, just like other webinars, is being recorded, and also notes will be available at the end from the United for Global Mental Health website. So I'd like to come to Githinji, you first. You are the co-chair for UHC 2030 and has the bigger picture in mind on UHC as well as its mental health integration within that. What has stood in the way of UHC progress to date, and what opportunities and challenges has COVID-19 created in this regard? Dr. Githinji, please. Can you unmute yourself?
Is that better now?
Yes, thank you.
Good. Thank you very much, and thanks for inviting me. And the question you ask is a big one. You know, I have been in the UHC 2030, and we have discussed globally all the way from 1978, even before UHC 2030 was formed. You alluded to it, that health for all as a right, as a human right. But early on in around the 80s, and I'll make a bit of reflection around where coverage is very low. That would be the global south, Asia and Africa especially. And we found that after 1978, there was a big drive to achieve primary health care for all. In other words, it was seen as the issue or the approach to addressing health as a human right for all. And starting with primary health care and making sure it's available to all without financial difficulty was seen as something that was going to be achieved. And many governments did start to move towards this journey, but somewhere around the 80s, the rain started to beat us because governments started to balance between health as a cost and infrastructure as an investment. And this narrative was also driven partly by the World Bank ideology at that point. And governments, when governments ended up in a lot of debt, they were then dissuaded from investing in costs and investing in what was seen as infrastructure and other areas. And therefore, the primary health care, which was seen to be accessible to all without financial difficulty, started to introduce fee sharing, and people started to be asked to pay some money for whatever services they were accessing. And that is the problem we find ourselves as you fast forward to now, even by 2015, when we're ending the MDGs. The biggest concern was out-of-pocket expenditure, and therefore the increasing inability to access health services. So we now bring in the concept of universal health coverage as a reversal of these challenges of introducing cost sharing. And UHC now is looking at how do we continue to deliver primary healthcare services where people need them, when they need them, but while removing the financial burden. So the challenge initially was that health was seen as a cost rather than an investment, whereas we have now seen, even with COVID, we've seen that health is actually an investment for the economy. Without a healthy population, you cannot have a healthy economy because you don't have children who can learn, you don't have adults who can earn. And therefore, this has been the initial challenge. Now, the next thing is, as we move forward now, we start to reflect on what could be those challenges that even as governments now realize post-MDG that the need to have health for all without financial difficulty is critical, as we have captured UHC. Last year, we had a big conversation around the UN high-level meeting on UHC, the high-level declaration. And we had many debates, and most of these debates had to do with political will, where some of the members of WHO and UN member states were seeing certain populations, for example, as not deserving of health, for all. We had challenges embedding some of the services that we are discussing now into the declaration to make sure that everyone is provided for in terms of all they needed. So we came up with a guide in terms of the areas we need to focus on. One was that health needed to be a political and a social contract between the politicians and the communities. And political will has always been a problem in many areas where declarations are made, but they are not followed with actions beyond that. The next thing was the area about leaving no one behind. That actually we find within this will there's a challenge to actually make sure that everyone has access. So we end up with providing healthcare financing that only covers a few people and not everybody. So that's the other issue that we find that's a problem. So we have iniquities, we don't have community voices at the center. The next area is that we have legislation and regulation that does not allow us to achieve health for all in the way that we envisage it, especially when you come to promotion and prevention. When you come to mental health specifically, we have countries that still uphold suicide or attempt as a criminal issue. These are issues of legislation, regulation that need to be addressed so that health is to go beyond just the service delivery. The other one is quality, and the quality is tied to something we call investing more and investing better. And this is tied together with financing. We still have challenges of financing, especially in Africa. We see that, whereas we have low investments in health, we have a high population, very low per capita expenditure, but that's compounded by a fiscal challenge where countries are not able to raise enough taxes to actually pay for healthcare. Beyond that, they are not able to achieve their commitments of 15% or even 5% GDP. So the financial issue is beyond just affordability. It's about political will, but secondly, it's about the fiscal space. And finally, lack of engagement of communities, of the sector, which is what we call moving together. So these are kind of the framework which we need to look at the challenges toward UHC and also the political cycles which kind of do not allow our politicians to focus on health as a long-term investment, and they want to see it as a short-term investment for vote patterns, which means that they are looking at secondary and tertiary care, infrastructure-driven health investments versus primary health care, which is people-centered and community-driven, which then means that investment in mental health is left by the wayside because it doesn't present a good opportunity for vote hunting.
Thank you.
So this
Dr.
political environment
Githinji,
is also a problem. I will stop there. Thank you very much.
Thank you for giving us the background, and also thank you for pointing out that health should be an investment and not a cost. That's so beautifully put. Let me go now to Devora and ask her about the WHO's stand. Devora, why is integrating mental health into UHC important as such, but also during the COVID-19 response and recovery plans? And what is WHO doing for that?
Thank you, Shekhar, and thank you, United for Global Mental Health, for this for the opportunity to be here today to discuss this critical issue, I would say. As you know very well, when announcing the need to have an initiative, a flagship on mental health, Dr. Tedros, our Director General, said, and I'm quoting, "The world is accepting the concept of universal health coverage. Mental health must be an integral part of UHC. Nobody should be denied access to mental health care because she or he is poor or lives in a remote place." And this was said way before COVID-19, right? But I think that this is even more relevant now than what it was before, maybe, because we have seen the impact that COVID-19 is having on the mental health of people at global level. I'm talking about the psychological distress that is caused by the virus to those directly or indirectly affected by the disease or the death caused by it, but also those that are involved in the response, such as the health professionals and others that are first responders, the consequences of isolation, the uncertainty that about the future and the perspective of this economic turmoil that we are already seeing in some countries. All these factors that are contributing to creating a situation where mental health and well-being of entire societies are impacted. So what we know is that at global level, mental health does not receive enough funding to absorb the existing situations, but also this increasing demand. And we know that the challenges that are coming already are bigger if or when mental health is considered as a parallel system managed by a so-called specialized isolated service such as the traditional mental hospital. So on the contrary, what we have seen so far is that countries that where mental health is integrated in the health system have the potential to be better prepared, or their possibility to be responding better is higher. So if we can consider mental health as part of the universal health coverage, we should be available to make services accessible to all who need them. With the whole of society approach, so not only in the health sector but beyond. We are talking about economic issues, and we are talking about responsibilities from governments or from other partners that go beyond the health sector. But within the health sector, then specifically, we need to see mental health clearly integrated in primary health care, as mentioned, as an old dream, but now is the opportunity to see it happening. We need to see it integrating in other programs, all those areas that are particularly affected by the virus, for example, but also the consequences of the isolation in some groups, such as the gender-based violence we have heard about a lot, also some of the NCDs, the children and adolescents aging. So special attention for groups in position of vulnerabilities, and that may need more than ever this kind of support right now. So we need to see this context of COVID-19 as an opportunity to integrate mental health in any response or recovery plan, as per the question. We have seen examples of this integration is in big frameworks such as the Global Humanitarian Response Plan, and we need to see it also at country level. I think for now that would be my first answer.
Thank you very much, Devora. That's excellent. You see COVID-19 pandemic, however unfortunate that may be, as an opportunity to reinvigorate the attempts to integrate mental health within the UHC. That's excellent. I now go to Akwasi. Having heard the global background and the global perspective, what efforts has your country made pre-COVID-19 in mental health integration into UHC? And have these efforts become more urgent since the pandemic has started?
Well, thank you very much, Shekhar, and thank you too for United for Global Mental Health for having us here. Yes, the journey for mental health to where we are now has not been easy. but we are happy we've come this far, and we hope that we'll be able to move further. Now, Ghana and UCH generally, Ghana has been, even before UCH was pronounced or was proclaimed, we have started UCH, universal health coverage, universal health coverage all along. Before 1978, we had health posts in almost every village where at least some basic dressings were given. And now, of course, the 78 matter came to confirm it. And we've been moving on. Mental health initially was not exactly very much in line, but by and by, with various advocacy, NGOs and whatnot, we were able to get mental health to be accepted. Passage of the mental health law and the LI. And now every district hospital, every health facility, a regional hospital, district hospital, is having mental health care integrated into it. And that has been really very good. Recently, with respect to the COVID, the president made a pronouncement. The president of Ghana made a pronouncement that the COVID pandemic has shown gaps in our healthcare generally, and specifically in mental health care. And that was an interesting pronouncement for him to recognize that mental health care had a big gap. And then he went on further to say that as a response to the gaps that we have, to fill in the gaps and a response to the containment of the virus, he was going to build 94 hospitals across the country, 6 regional hospitals and 88 district hospitals. Of course, people were doubting, but that was the program that he made, and he has actually started the process of doing it. What we have in mental health care is that we have been able to negotiate and decided that 2 of the hospitals will be psychiatric hospitals in underserved areas. If you look at Ghana as a whole, as a country, and if you divide us into 3 zones, the northern zone, middle zone, and southern zone, all our current 3 hospitals are at the southern zone, leaving the middle and the northern zone underserved. So we have negotiated that the hospitals is going to build, 1 will be in the middle zone and 1 will be in the northern zone. Apart from that, each of the 94 hospitals will have a psychiatric component. And that's been really very good. We've discussed with them, we've negotiated, and they've agreed. All the drawings and the architectural drawings are part of it. And that is really very wonderful. So people have really seen that the gap in mental health care has been filled. And COVID has really exposed us, and the commitment is to fill it. And that's been very wonderful.
Thank you so much, Akwasi, for telling us about the progress that Ghana is making on UHC as such, but also in integrating mental health care within that. I was thinking of checking whether Peter has been able to join, Peter Yaro. Peter, can you hear me? He was having some technical difficulties, so I am so sad to note that he has not been able to join. And if he does join, we'll come back to him. But I now go back to Githinji to explore a little more. In very brief, we know that there is a danger, and some people believe this is a real danger, that health budgets will become more restrained due to COVID-19. With countries spending a lot of money on vaccines, spending money on buying ventilators and other things. Is there a danger that mental health financing will become actually even more difficult to get within the countries and will not be part of the integration within UHC?
That is very true, and we are going to see that governments are going to struggle with the fiscal space, and because, as you say, the money is being diverted, and beyond money being diverted, we are seeing that we are going to have a recession, and within that recession, the government will be able to tax. We've seen governments actually giving tax breaks to their population. I've seen that in Ghana, I've seen that in Kenya, I've seen that in other countries, where even the value-added tax is being reduced. So basically, the fiscal space is going to get smaller. So, conditions like mental health are going to get less allocation. We know that especially many of the acute diseases, the acute infections like HIV, TB, malaria, are heavily provided for by donor funding. Conditions like chronic conditions like mental health are not provided for by donor funding, and secondly, are also not provided for by domestic financing. So when this space of financing reduces, then the problem is exacerbated. So there are a few things I would like to mention that are needed to make sure that we protect and increase investments in mental health. One is we need to work with governments to institutionalize universal health coverage and its financing. Institutionalizing universal health coverage means that governments have policies, legislations that make this social contract real through policies, that UHC is actually something that is a right to a citizen. Secondly, institutionalize the health benefits package, because when you talk about UHC, the delivery mechanism is you must have a committed health benefits package that you're financing. Now that should include mental health all the way from community level, primary health care, to secondary and tertiary level where it's needed. So it needs to be embedded in the health benefits package. Community participation, that communities need to be at the center, not as recipients, but also caregivers and participants in generation of mental health. And finally is accountability, that if we don't have accountability by communities, by those people with lived experiences, then the government process become just that, care and promises without action. So those are the ones to highlight in terms of safeguarding investments in mental health and specifically universal health coverage.
Thank you very much, Githinji. In fact, that gives me the possibility to ask the question on accountability to Peter, who I believe has joined us, although we cannot see him on video, but perhaps he can hear us. So Peter, I would like you to pick up the thread from Githinji to say, can civil society be providing a mechanism for accountability, and to what extent is that happening or is likely to happen in Ghana?
Thank you very much. I hope you are still hearing me, even though you may not see me. And thank you to all the previous panelists for such insightful discussions. Yes, when it comes to civil society involvement and civil society demanding accountability, it is from the point of view of civil society trying to demand what is ideal, what should be, not what has been managed to be in place. Politicians and sometimes people who work for government may want to ask that you commend them for the little that has been done. But we would say, no, you need to do a little bit more than that, because there is enough reason and justification for that, because the people require what you are providing, and the amount or the level provided is not enough. So there's a certain level of moral accountability that civil society brings to bear on government and on public and civil work. Listening to Dr. Akwasi, who we have worked with as the Mental Health Authority for all these years, it has always been that complementary rule that is brought to enhance what government does. And because of that complementarity, you have a certain position to ask that more can be done. So how do we do it in Ghana? We have closely worked as an alliance of similar organizations coming together to prosecute an agenda of one, collaborating with the Mental Health Authority that has become a kind of lone ranger in the scheme of affairs in government, where the likes of Dr. Akwasi and his hardworking team shout their voice hoarse just to catch the attention of government. And we come in there to say, look, this is a voice that needs to be listened to, and find out how else can we work with the Mental Health Authority to improve what is required for the people. So the Alliance for Mental Health and Development, which are quite a group of many actors in mental health, human rights, addressing issues of accountability, addressing issues of child rights, addressing issues of mental health users, use this platform to demand of government. That reduces the level of victimization of a state agency like the Mental Health Authority. It also allows us to go into those areas that authority would be seen to be outstepping it bound. But we as civil society don't have to answer to anybody except the people, the masses of the country. And this is how we have done that. And he mentioned the mental health law, but within this COVID pandemic, civil society has asked that relief support to persons living with mental health authorities or the poor and vulnerable should factor in people with mental illness and their families. And I've actually gone on to demonstrate this through the SDG coalition. We have continued to ask that testing be extended and that mental health care services should not suffer because of a response to COVID. So let me just pause here and then I can come back.
Thank you so much, Peter. I'm hoping that these will not remain mini voices. They will be loud and clear, not only in Ghana, but all over the world. So thank you for explaining the actions that you're taking to ensure accountability and to make sure that the voices of people with living experience are heard loud and clear in the policy making that is taking place. Let me go back to Devora. And I have something, a question that is something similar to what I asked earlier. Is there a danger that finances for mental health all over the world, but also for within WHO, will actually be under strain? And is there something that you're seeing on that side? We know that WHO finances are under a lot of strain. A particular country has actually stopped contributing to WHO. Do you see any danger, or do you think there is this opportunity that you talked about is becoming real so that you can actually implement the special initiative on mental health more vigorously than earlier?
Thank you, Shekhar. I wish I had the answer to that, because it meant that I for certain know what's going to happen, and I don't. I think that is true. The risk is there. The challenges are there, but in the same way that some countries withdraw, other countries contribute. And the issues around mental health are clearly out there and are being highlighted by different levels from the senior UN authorities within the UN agencies to countries and civil society, as Peter just told us, etc. So as a consequence, I think that, again, this opportunity is going to be translated into concrete action. You know very well the special initiative that we have launched last year is called Universal Health Coverage for Mental Health. And clearly, those countries that have a better system, as I said before, are responding better to the current challenges. So the countries that were already involved in special initiative, to my initial surprise, I may say, they have been moving ahead despite the challenges. In the middle of the lockdown, workshops were taking place in order to draft the strategy and the design planning that each country was supposed to do as per agreed plan. And we are efforts are taking place at country level, like you understanding more than ever the need for a strong integrated mental health system, but also then efforts are going on at different levels from our side and other partners to ensure that funds are going to be there to support these efforts. The integration is critical. It was critical before, we said it already, it is critical now. So if we want to really see a difference right now and making sure that some funding goes to mental health, it will have to go through this integrated approach. I don't think we will have something that will go to support isolated services. This is not the way. It will have to be through integrated approach. And soon, hopefully, you will all hear about some of the ideas that we are having and the plans that we are having in order to make sure that this is something that attracts a partner, that we understand how by investing in mental health, some of the issues that were just mentioned, I don't want to repeat by the colleagues that spoke before, will be seen as a better outcome for the populations, the affected ones that now these days we can say really globally.
Thank you so much, Devora. And we all are optimistic that WHO's attempts to integrate mental health within the UHC will succeed better than what was planned earlier. But let me now go back to Akwasi again to talk about a country experience. Akwasi, you talked earlier about what has been done. Now I want to go to the future and say, what do you attempt to achieve in the next 1 year, and what will success look like to you?
Yeah, thank you. What we intend achieving, and by the way, when I said the president intends building 94 hospitals, he wants to do that within 1 year. So within 1 year, we expect that mental health care would have been spread nationwide, rather than just centralized in the southern part of the country, now nationwide. That is one. Two, you would expect that every hospital, in fact, every health facility, right from the big hospitals to the smallest, which we in our context we call the CHIPS zones or CHIPS compounds, they will all be attending to persons with mental health care. And we expect that every health worker, irrespective of being mental health or any other health worker, would at least have been trained in mental health gap and MH gap, and also be able to administer at least first aid mental health care. We also expect that not only the services there in terms of facilities or structures, but also psychotropics, availability of which has been a major problem now. We expect that that issue would have been solved. And then finally, financial sufficiency. Government hasn't so far reduced its funding for mental care as a result of the COVID. But the point is, even if you double it or triple it, it will not be enough. So what we want to put in place is a sustainable mechanism, and we've talked about a levy, mental health levy, which is in the law. If this is implemented and it's there, then every now and then we are getting funding for mental health care. Then you'll be self-sufficient, and then you'll be able to implement all the plans and ideas that we have. And that's what we expect in the next 1 year.
Thank you. That looks like a very ambitious plan. And I would like to now go to Peter and ask a question. Peter, you just heard about Akwasi's plans for the next 1 year, and we are all wishing that that will succeed. Do you have an ask from him? If you were in his boots, would you do something even more than what he's saying?
Thank you very much. It's good to hear the presidential initiatives. Where I would have started first would be that financing and sustainable financing of mental health be demonstrated by government in the budgetary allocations. We are even yet to see the designs of these hospitals and whether they factored in community mental health wings. We have seen recent times that have been ignored. So to start would be to see that those initiatives that just need little funding. I think Dr. Akwasi mentioned medicines, but there is also need for continuous professional training of a cadre of health workers to ensure that mental health care services don't become as specialized as they currently seem to be within a few overstretched staff. So a massive effort to share skills, to share the burden of healthcare right up to the community health planning and services, what we call CHIPS facilities, should be for us what should be the case. The hospitals will be an icing in the cake, and I like the idea you said. That is really ambitious. It's always good to think big, but it's also clear that a year doesn't seem realistic. So we should look at those cost-effective, doable things whilst we work towards realizing this ambition, which is all good for us all.
Thank you so much, Peter. Thank you for suggesting some ways in which the Ghanaian government plan could be made even better. And I think I really respect you for saying, let's be realistic and do something which can impact on everybody's mental health. So getting it decentralized and increasing the capacity of the healthcare workers to do that. Now there is a rapid fire round where I'll ask a question and I'll indicate to one of the panelists to answer it within a minute, if that is possible. The first question is to Devora, and this is coming from one of the attendees. What is WHO doing about improving self-care for mental health? Because we know that WHO has given the pyramid of mental health services, and at the bottom is the self-care and informal community care. Are you taking any actions to increase that?
Somebody was entering my office. I'm sorry, so I got a bit distracted. I don't know if I remove. Yes, I put my mic because I was making signs there. So I'm sorry. Thank you for that question. But I think I missed part of it. You were saying, if you don't mind, Shekhar, you were saying that we are talking about the pyramid of services, and then I didn't get the last part.
Is WHO doing anything on the self-care and informal community care?
Sure. Thank you for very much. We just came up with a couple of recent publications. One developed in collaboration with other UN agencies in the context of COVID, precisely, that is psychological basic skills for first responders, and that is a very simple tool with very specific tasks and a very friendly done that serves at precisely all different actors at community level. It is thought planned for the current context, but of course goes beyond and could be of use in any situation that may have similar characteristics. And I highly recommended it. Basic Psychological Skills, a Guide for COVID-19 Responders is the title. Now, and that's the latest one. There may be others, but this is the more recent one. Then a project that was started before COVID, but was recently published in this context, and because it serves precisely for self-help, is it is called Doing What Matters in times of stress, and is again a very simple, agile, friendly guideline to help us doing what matters in times of stress. There is there isn't much more to add to such a clear title. It should it is translated in several languages, both of them already, and it should really serve the purposes for the question asked. Sorry for the interruption.
Thank you, Devora. I think it's very important to emphasize that WHO has a number of technical documents available in many languages, and I will hope that many of the attendees will actually go to the WHO website, download some of these, and actually start using that. My next rapid fire question is to Akwasi. The question from one of the attendees is, what is the role of community health workers and what are you doing to train them?
Yeah, thank you. Community health workers, in fact, community mental health generally is a pivot of our new paradigm, mental health care, where we are moving. We have deliberately decided that we are moving from a centralized care to a community-oriented care, and the community mental health workers are the pivot of that area. So within our scheme of affairs, we have community mental health care as at the front, being at the front line, and we have a focused program of training them. Our handicap has been funding to enable us to train them, but this year we hope that we will have enough funding that we go to train them. So we have community mental health workers down there, and a little above them, we have, if you come to the clinicians, we have physician assistants and clinical psychiatric officers. In fact, we are even grouping in what we call informal community mental health workers, who are the traditional healers, faith-based healers, because they are in the community. We need to lay a lot of emphasis in the community. So community health workers and mental health workers will have a big role to play in mental health care in Ghana.
Thank you so much. We are just around the end of the time for us, but I would like to ask each one of you to say in 30 seconds or less a key message that you would like people to remember. Something that you feel is extremely important, but just one. So I start with you, Githinji.
Yeah, I would just like to say that I know that mental health financing is important, but we need to advocate for universal health coverage financing, which is inclusive of mental health financing, so that we realize that there will be no mental health without universal health coverage. So that is the message I would like to leave behind. And I want to convert every mental health advocate to universal health coverage advocate with comprehensive mental health as part of UHC.
Thank you so much. That's really a good take on that. There is no mental health without universal health coverage, but also no universal health coverage without mental health. Devora.
Thank you. Well, I was recalling that in the occasion of the recently launched UN policy brief, UN Secretary General policy brief on mental health, the UN Secretary General Guterres said that mental health should be an essential part of government's response to COVID. And as I mentioned earlier, the Director General of WHO has stressed the need to integrate mental health in universal health coverage. So there is not much more to add to those sentences, except that we need to use this as an opportunity to build back better a mental health system that is responsive to the needs of those affected directly or indirectly by the pandemic and beyond, of course.
Thank you very much, Devora. Building back better, the key word for all our attempts now. Akwasi.
Yeah, thank you. I would say that, well, the COVID is a crisis, but it's come with opportunities. So we need to take advantage of the opportunities. Specifically, I want to say that we all need to recognize mental health care as a collective responsibility. It is not the responsibility of any particular somebody sitting somewhere, the government or anybody, but it's for all of us. We all have a role to play. And if we play collectively, self-care, the community level, the government, NGO, civil society, collective responsibility, then we'll be getting somewhere very far.
Thank you so much. It is indeed a collective responsibility. And Peter, with that, you will have the last word. So your key message. Peter, are you still there?
Yes, I'm here. Thank you very much for the opportunity. I think I'll reiterate that the theme of it, that there's no help without mental health. But it's also more important that mental health goes beyond medical considerations. We should find ways to include service users, civil society, and link up to other sectors of society and our socioeconomic development to realize better investments and more investments in universal health coverage that would cover mental health.
Thank you so much, Peter. And with that, we need to close, but I want to thank all the speakers who joined us from wherever they are right now and spend time with us. It has been very informative, at least to me. So thank you again so much. And thank you all attendees for coming to us. There will be a webinar next week again at the same time. And so do join. The topic is LGBTQIA+ and its relation to COVID-19 and mental health. And just to also remind, there will be discussion continuing on social media. So use the hashtag and join the discussion to continue. And a recording of this webinar will be available along with notes. So again, thanking everybody. Bye-bye for now.
Bye-bye.